So good morning. We're going to introduce this first case. So 76-year-old Jehovah's Witness man from Nebraska with neurofibromatosis type 1, presenting with unintentional weight loss and imaging concerning for new mid-CBD mass on MRI MRCP. Labs demonstrated a total bilirubin of 3.2, alk phos 413, AST 131, and ALT 144. MRI MRCP from August 11th of this year showed can we please put the slide back? Oh, thank you. So MRI MRCP showed severe intrahepatic ductal dilation and proximal common bile duct dilation to 22 millimeters. An abrupt cutoff was visualized in the mid common bile duct with a 10 millimeter enhancing intraluminal soft tissue nodularity, and then a normal distal common bile duct. And it looks like they're showing the MRCP picture here, and we can see that cutoff described.
Okay, if we can go to the live feed in that room. We have Dr. Todd Barron. Todd, can you hear us?
Yes, can you hear me?
Can the audience hear Dr. Barron?
Yeah. Good.
All right, so we see the back of your head, Todd. It's a very good look for you. And I believe there is another camera of you there, depending on where you are. Okay. You rearranged the room for us. Todd, can you hear us?
Ooh.
Okay. Well, what we're seeing here, for those of you who are somewhat familiar with EUS or not, but that I believe his echo endoscope is probably in the duodenal bulb, and we have Todd. I don't know if you can hear us. Can you hear us now?
I agree. It looks like he's seeing kind of the dilated, maybe common hepatic and the portal vein inferior to that.
So while they're working on the sound, I think if you can hear us, I guess they can't hear us.
Do they turn? Who controls your microphone? We do, or?
Yeah. Okay.
Case. We
Okay.
can talk when we do the case.
Okay.
I think they can hear you.
Okay. All right. So we have the scope. Probably common hepatic duct because the liver is on the left-hand side. You can see the bile duct as it comes into the liver. So that'll clearly be common hepatic duct. You see liver. I'm going to rotate the scope clockwise, and what's interesting is you see a stone right there with shadow. You know, on this. Abrupt change in caliber right there to normal, relatively normal caliber duct right there. Again, twice, right there, the mass, which is 18 to 20 millimeters.
Can you guys hear him okay? It looks like he's pointing out there is a hyperechoic stone with shadowing, but there's also a soft
On this,
to the right of that.
this gentleman is whether or not to get a tissue diagnosis by EUS guided biopsy. He is late 70s, so and he doesn't look to be the healthiest person. Certainly, transplant would concern because we're going to go through the duodenum, but he wouldn't necessarily have a Whipple. So if the duodenum remained intact, there's a chance for tumor seeding along the duodenum wall. That risk, we don't know the absolute risk, but we do know that's a concern. Whether or not he would get chemo pre or post that would change that or decrease that risk of that being clinically relevant, I'm not sure. But really nice imaging that shows you, again, I'm looking at the downstream duct right above right in my arrow. And then counterclockwise, there's a lymph node right there that's benign appearing, portohepatous lymph node, malignant appearing lymph nodes, very hypoechoic, very round. This looks triangular, has a germinal center.
Yeah, he's cutting.
Here from Rob.
So Todd, can you hear me? This is Raj.
The RCP and either simply do brushing, although the sensitivity is relatively low for brushing. We could do intraductal biopsies without cholangioscopy, although the yield is probably lower from just fluoroscopically guided intraductal biopsies as compared to cholangioscopy direct biopsy. So we could do that as well, because again, we're going to be doing the EPs. I'm waiting to hear from the team of how they would like to proceed. It doesn't look like he has any involvement of the vascularity. The portal vein is below the mass. It doesn't look to be involving the portal vein. Where my cursor or arrow is I have in the hepatic artery.
Hey Todd, can you hear us, Todd?
With Doppler. So vascular, it doesn't appear to be vascular invasion at this point.
So I think hey Todd or Jerry, can you hear us? Okay, so.
Oh, hi.
So I guess you can't hear us. I thought they had delayed the launch of NASA to the moon, but it feels like we're transmitting from
Raj,
the moon.
what do you want me to do?
But yeah, so it's I think the dilemma here is that the issue is, I think, the transduodenal biopsy and whether you do transduodenal biopsy in a patient that the lesion is upstream of the intrapancreatic portion of the bile duct. So if they were to go for a resection, it would be a primary bile duct resection and a Roux-en-Y. So the duodenum would be left intact. And so we generally try to avoid FNA, FNB of transduodenal biopsies of hilar lesions or common hepatic duct lesions that are not going to be resected at the time of surgery. And Dr. Barron was mentioning that the patient is a poor operative candidate. So then it may not matter. I mean, if they're a poor operative candidate, they're not going to be a resection candidate or a transplant candidate. Really nice. So in my opinion, I think sampling this would be okay. You have to be sure that that you're
Well,
doing an
the distance
ERCP because of the risk of
would
bioleak. And
be
I don't know, Jeff or Urban, what you think about
from here
the concern of
to
possible, bioleak in an intraductal lesion.
6. So
Yeah, I think there is
the 8
that
by 8
concern,
would be-
but the thing you have to look at here is
So we're just,
EUSFNA will probably be
I
the most
presume you guys
sensitive
can still
sampling
hear us.
modality for this, since it is extrahepatic and you do see a mass. And so I think, you have that modality would have the highest likelihood of giving you an answer compared to the other things that he was discussing, like brushings or intraductal biopsy. So I think that's part of his internal debate. But no, in this, I would definitely follow that immediately with an ERCP and placing a stent.
Natalie, what about you?
Yeah, I do get concerned in these cases about biopsying the bile duct directly and potentially causing a bile leak if I can't get in. In this case, the distal bile duct's not involved, so I'd be reasonably confident that hopefully we could cannulate and get a stent in after biopsy. Sometimes too, I'll do the ERCP first and then biopsy with the stent in place, kind of knowing that I have that stent protection in place. I have a question too for you guys. So he mentioned that the lymph node was benign appearing, which it does have the features of a benign appearing lymph node. It's heterogeneous, it's not well defined, but in cholangiocarcinoma, involved lymph nodes can not have classical malignant appearances. So, he's not really, it sounds like based on his history, a transplant candidate for cholangio or a surgical candidate. But what do you guys think about biopsying benign appearing lymph nodes in patients with suspected cholangio to help with staging? I know for our transplant protocol, for patients with potential like hilar cholangio who are going to undergo transplant, they want all benign appearing lymph nodes around the hepatis biopsy, concern for they could potentially have harbor malignancy despite typically benign appearing features.
Yeah, I think if the lymph node is malignant appearing, I think that would be a good place to lead with taking samples, because certainly that would answer your question as to whether or not he's a surgical candidate. I think since they're considering resection rather than transplant in this patient, I don't know if you necessarily need to biopsy a benign appearing lymph node. Because, if you have a tissue diagnosis and this is a cholangio, they'll probably follow it with additional cross-sectional imaging to look for broadly for any evidence of metastatic disease. So in this case, I don't think I would biopsy the benign appearing lymph node, but I'd be interested to hear what other people have to say. Because it does look like it has ultrasound characteristics of a benign lymph node. You can see a cortex, a medulla, the shape of it suggests that it's benign.
One thing we're going to try to communicate to Dr. Barron, we're going to try to transition to another room until the audio is figured out. And but I wonder, just real quick, would any of you bypass the introductal sampling? I agree with Natalie that we stage for known cholangiocarcinoma with nodal sampling, and sometimes the node appearance with cholangio especially is may look benign, but they're actually malignant node. And I think that the other consideration is just going straight to introductal sampling and cholangioscopy as well. And this candidate may not be a great surgical candidate, but I don't know that for sure. So we'll go back to him, and I think we'd like to go to the next room if we can get the case presentation up. This would be case number 102, I believe. If we could show case number 102. And I also have heard that Dr. Hadry's,
So
Dr. Hadry will also be joining us here in a minute, so virtually.
is there a way we could get the case description PowerPoint on the front screen, the live screen? So this is a 65-year-old colonic fistula, 60, you guys are keeping me on my toes this morning. 65-year-old male with a history of long-standing GERD who underwent diagnostic upper endoscopy, which revealed salmon-colored mucosa in the esophagus, consistent with C9M10 Barrett's esophagus. 4-quadrant biopsies, I lost it.
I can kind of read it in here. No,
4
There.
quadrant biopsies were performed every 2 centimeters throughout the entire Barrett segment. Biopsies revealed high-grade dysplasia in the lower third of the esophagus, which was confirmed by an expert pathologist at the University of Colorado.
so I think we'll be going to Dr. Wani's room. And we have Dr. Hadri joining us. Hi, Rayhan. Thank you for joining us.
No worries. What an absolute pleasure to be here. Sorry, I can't be there in person.
We have, we are
Hey
going
Raj,
to.
can you hear me?
Can you all see Dr. Wani up there too? Okay, great. Hey, Sachin, can you hear us?
I can hear you, Raj. Can you hear me?
Hi, Sachin. If you give me a thumbs up if you can hear us. Okay, great. We can't hear you, but I have some experts here that can certainly talk about this, what you're doing. So I
Raj,
think
can you
that we'll
hear me
have to
now?
do that for now until we get the audio figured out. And
Good morning. Can you hear me?
Yes, a little bit.
this is the stomach. There's some little benign polyps, right? You want to do anything about that? Patient on a PPI, maybe? Am I getting pretty good at this? Okay.
Yeah. Is this turned on?
It looks like he has a cap at the end of his upper endoscope. Do you guys routinely do your Barrett's exams with a cap?
Raj, can you hear me?
Yeah, I can.
Awesome.
exciting.
Great.
Yay.
Good morning, Raj. It's Bonnie.
Morning. How's everyone doing?
We're doing great. We're excited to see
Awesome.
what you're showing.
Yeah, I've never been so excited just to know that you guys can hear me. Okay. Nice to see everyone. I just wanted to introduce the team in this room. Experts. It's actually 2 of them in the room here. I have Mani Konda from Texas. I have Dr. Hazem Hamad. The fact
So it's Vani Konda and Hazem Hamad.
expert.
We're having a little bit of difficulty
joining
hearing
us
you.
from Nairobi, Dr. Rayhan Hadri. So you heard about the case. This is a patient who was referred to our practice for a diagnosis of Barrett's with high-grade dysplasia. I'll cut to the chase. And Bonnie's gonna talk to you about what we've seen so far and talk about the basic elements of high-quality endoscopy for a patient with Barrett's esophagus.
So as we've been watching this exciting stomach, that's where we start. And we always want to make sure we don't over insufflate the stomach as we're going through our landmarks. And that's the first thing we're going to do. We're looking for that first pinch, which is the diaphragmatic pinch that we can see here as we go from the stomach to the esophagus. And then we're looking for the top of the gastric folds. And again, if we over insufflate that, sometimes we can miss a subtle hiatal hernia. And sometimes patients with Barrett's get misdiagnosed in their length because the hiatal hernia can be incorporated in their length. So it's really good to take some time and appreciate where the top of the gastric folds are, which we can see right here. And then we continue to see this salmon colored mucosa on, and I want to point out that we have a soft distal attachment cap, which is one of my favorite tools. I don't know what you guys think, but it really gives you a little bit better visualization. You get to be able to inspect the gastric folds, but even in the tubular esophagus, you get good en-face imaging, and it really, I think, is a critical part of all of our Barrett's examinations. We're looking here as we're coming up for any areas of irregularity, any abnormalities in the contour of the wall, and any discoloration. And so
I think, Bonnie, we should also talk about another unique aspect about this case. So far, what I've done is really inspected the Barrett's using high definition white light endoscopy. That really is my first go-to imaging approach, and then follow that with virtual chrome endoscopy. Now, this patient, when we actually started, was noted to have.
Hey, Sachin, can you hear me? You know, I'm wondering, we can hear Vani really well and you not so much. Am I right, audience, or no?
Yes.
Yeah. So I'm wondering, I don't, because I definitely know your voice projects. And, how about now? Can you,
Okay.
oh, wow, that should,
How about now?
How
that's
about
gonna
now?
be serious feedback, but try it.
Is that better, Raj?
That's better, yeah.
Okay, perfect. So another aspect about this patient is the fact that he is allergic to PPI therapy, and he's on a H2RA, which he takes ranitidine once a day, every night. So we're limited in terms of the medications that we can give him to manage his reflux. So we actually encountered a stricture when we first went in, right here at the top of the Barrett's. So you heard Bonnie talking about defining the length of the Barrett segment, the column-aligned esophagus. So we did that. We marked the top of the Barrett's, which is essentially at 27 centimeters from the incisors. I will tell you that I had difficulty traversing this with a standard upper endoscope, so I had to, and with a distal attachment cap, so I actually dilated this before we came live up to 15 millimeters. All right, so now I'm going to switch to NBI, and this really is the most critical part of this exam, because it allows us to really identify the area that harbors dysplasia, guides endoscopic eradication therapy, and predict histology as well. So Vani will talk to you about the things that we see on NBI.
So with the NBI, we also have an option in some scopes on the Olympus system with a magnification feature called near focus. So when you have the narrowband imaging without near focus, you can sort of look at the whole lumen. When you have the near focus on, you want to be about 2 to 6 millimeters away from the wall. So you might see us switching back and forth. But right now we're inspecting, and you know, sometimes it's good to have a systematic approach. So we were talking before about how I think both Sachin and I use a quadrant approach. So, you know, I would go and sweep ones all the way from the distal end to the proximal end, and then go through and really look at one quadrant at a time, focusing our energy to look at the mucosa. And we're looking for two main features, the mucosal pattern and the vascular pattern. And although you may see some variation and variability throughout the lumen, really what we're seeing is that everything looks somewhat like regular to where it is, and there is some pattern that's intact. And so it doesn't have to be the same pattern everywhere. But when it starts to have an irregular pattern, that's when you worry about neoplasia. With vascularity, you sort of want to make sure that either you see the vessels follow the mucosal pattern or have some branching long thin pattern that they are preserving on their own. And so right now we see there may be some areas that are a little bit more ridged, some areas that are a little bit more circular, a few areas that are even a little bit more cerebriform, but all in all, the vascular pattern and the mucosal pattern so far have been relatively well behaved. And this is the near focus feature. And this one, you really have to be much closer to the wall. And so this is gives us a lot more definition. And you can see the vascular pattern here, really following the mucosal pattern. And again, you want to be about 2 to 6 millimeters away to have this imaging feature on. Now, as we're moving up, I want you to pay close attention to see when, you know, this sort of shifts or changes. Disregard those white marks.
Yeah.
Okay, so here at about 2 o'clock, we can see a different pattern, and we can see the mucosal pattern is starting to get a little bit distorted, and the vascular pattern no longer follows the mucosal pattern, and you can sort of see almost that neovascularization appearance between 2 and 3 o'clock, sort of really behaving in a different way and doesn't follow the lines of the mucosal pattern.
Yeah, no, completely agree. So these are abnormal findings that you can see in patients with suspected dysplasia. Really does not appear to be raised at this point, but as I move more proximally, you'll appreciate some areas of nodularity. So here you can appreciate this area looks a little more nodular, but this is also in the setting of an esophageal stricture. As I move a little more proximal, you can appreciate this area that definitely appears to be nodular. I would call this Paris 2A. Yeah. Rehan, what do you think? Based on what you've seen?
Yeah, I think I just want to commend the moderators for being able to shut you up. I've not been able to do that in 10 years, so congratulations. Look, I think you've very elegantly demonstrated the area, the anal end of this lesion is very subtle, and you've shown the mucosal and vascular. One has to just be cognizant that in the context of a stricture, this is likely to be a reflux-induced stricture. It becomes very difficult to make a decision as to what is normal, what is abnormal. But the dogma is a visible lesion in Barrett's needs to be removed. And I'd be really interested here in what your resection strategy would be here. Do you think mucosal resection would suffice in the context of a stricture? Or do you think you need to do an ESD?
Yeah, no, and that's what I wanted to poll all the experts. So as you can see, the white marks that Vani was referring to was the markings that we did before the dilation. My strategy to do that was I had no idea what was going to happen after we dilate the stricture and if it was going to mess up my landmarks and definition of these abnormal areas. So we decided to go ahead and mark in case we plan on doing the resection today. Thankfully, this area is still preserved. This was the area that I was most concerned about in terms of harboring dysplasia. Having said that, you can see the tear right here in the 12 o'clock position. So we have and I'm not so concerned about the areas here. We were pretty generous in our marking, but the areas that I'm most concerned about are from the 12 o'clock to the 6 o'clock position. One option is we just abandon the idea of doing any resection today, bring the patient back, assess the stricture, ensure that the stricture has responded to our dilation and perform resection during the next endoscopy. The other option is knowing that we've addressed the stricture right at the top, try and carefully resect this area from the 12 o'clock to 6 o'clock position. So, Rehan, I'll start with you. What are your thoughts?
Yeah, I think that's it's a very sensible suggestion. I personally think that if this was dysplasia in ESD, would probably be more appropriate, just because it's going to be very tricky. So personally, what I would do here, is sample these two areas in two separate pots. Proximal area there that looks slightly subsquamous, and then the more distal area to confirm that there is dysplasia. What you don't want to do is to overtreat this patient. There's a lot of confounding here from the dilatation. And so, if your forceps biopsy indeed showed dysplasia, then you could plan an ESD here and actually remove this area on block and probably do a sort of hemicircumferential block procedure.
That sounds reasonable. Bonnie, what do you think?
I think that's a reasonable option. I'd probably shy away from doing the resection today because I think there is an issue with the stricture. I don't think you're going to get the kind of margins that you would want with the stricture impeding both the passage of a bander, but also just even the navigation and manipulation. You'd want to do that kind of resection. I think, in terms of the difference between doing a piecemeal EMR versus ESD, aside from the stricture and the anatomic thing, I think that sometimes depends on just where everyone's comfort level is. Certainly an end block resection, when we're concerned about multiple sort of extensions of this lesion, does give us more certainty on the histopathologic stage, as well as certainty on getting everything. That may or may not be available everywhere. And I think that if a wide field piecemeal EMR works in Barrett, but still usually sufficient, especially because I don't see too many areas that we're very, very concerned about submucosal invasive disease. If I had a high suspicion, I might change my mind. But the stricture really, I think, makes it more difficult, and maybe even submucosal dissection allows you to do more in some ways.
I don't know, right? Hazem here, I agree with you with this style, well, more like a 2A area at 1 o'clock, there is some concern for carcinoma. I can't clearly see the subsquamous extension in this area, and it's right that the anastomosis the stricture as well. But my experience has been when there's like many areas of dysplasia, high-grade dysplasia, that you can't really eradicate all the high-grade dysplasia with ESD in a long segment. So I think either way would be okay. I personally prefer, when I see multiple areas of abnormality, to go with EMR, unless there is just one area of a sessile mass or depressed area that we can eradicate fully with unblocked ESD.
So to summarize, it sounds like you guys are planning on deferring resection today, now that you've treated the stricture, and we'll bring the patient back to perform the resection later on.
I think that's a very reasonable summary for this patient. I know you guys need to go to the next room, so thank you so much for joining us. Look
Thank you,
forward to
guys.
seeing you
Thank
again.
you, Sachin, Vani. Thank you, Rehan. Appreciate your input. We're back to Dr. Barron, room 16. Todd, can you
Okay,
hear
hi.
us? You've come back from the
So
moon.
we're getting ready to needle the mass. There are some small vessels around the lesion, but as we talked about off camera, the vessels you really worry about are the ones with names, so there are no names here. We got the mass here, and
Todd, how many passes have you done so far?
This is the first one.
Oh, first one. I see. Okay.
Yes, we were waiting for you. So we're in the lesion. You can go ahead and start. This is a needle shot, 3 Olympus needle. You can take the Doppler off. And it was mentioned in the talk yesterday about doing fanning. The scope position is a little bit odd. I think for lesion that's a little bit small, I'll try to do a little bit of fanning, but I think I'll be limited on that, just based on the positioning. But there you go. So I do as many actuations per pass as it takes to have the stylet almost completely out of the needle. And once our assistant says you're almost out of stylet, then I stop doing passes. So we're almost there. As you can see, we're keeping our needle in line. Okay, she's out, so I'm gonna take the needle out.
So it sounds like, Todd, you're doing the slow pull technique. Is that your
That is-
typical
yeah,
go-to for
yes.
F&B?
Yeah, and that's what I do. FNBs. I'm doing FNBs now, but we use the slow pull technique. I rarely use suction except if we've made a couple passes and we're not seeing what looks like pretty good cores of tissue, which is really uncommon, I occasionally have a really fibrotic lesion that doesn't really give up pores, then I'll add suction after I've done it. With the biopsy needles. So we're doing on-site path right now, and we're waiting to hear on that. But we stopped doing on-site path at our institution. I do a minimum of 3 passes, usually a maximum of 5, but usually more likely 3. I'll tend to do more passes patient that had a non-diagnostic EUS previously. So I might take 5 to 7 on that, but really in the order again of 3 to 5. Okay.
Okay, thank you, Todd. I think that's really good. I'm just wondering, oh, okay. Very good. We go on to the next case? We'll go back to Todd later.
So this is in a case of a esophageal stent plus minus stricturoplasty. So this is a 73-year-old male with history of GE junction adenocarcinoma treated with chemotherapy followed by an esophagogastrectomy with a gastric pull through. Can you go back a slide? Thank you. In November of 2020, which was complicated by a 1 centimeter stricture at the GE anastomosis. The patient underwent multiple balloon dilations up to 15 millimeter, which resulted in partial relief of symptoms. He then underwent stricturoplasty and ablation of fibrotic tissue with needle knife, followed by a balloon dilation to 18 millimeters and injection of triamcinolone in June 2021. He initially did well following this procedure before returning with recurrence of mild solid food dysphagia, along with significant belching and reflux symptoms, a 16-pound weight loss, and early satiety over the last few months concerning for recurrence.
Hello. You hear us? This is Muhammad Othman. Paul Leonore here. Can you hear us?
Yes.
All right. So, well, thank you everyone, and thank you for the amazing Colorado, University of Colorado team for helping me today. So, we have an esophagus full finding. We're just gonna go quickly to the GE junction and come back. Not the GE junction, the anastomosis. So the first thing we can notice here, we have significant esophagitis. This is very expected in patient who had gastric pull-through, and then we would see the stricture here. And the problem with strictures like that is that they have dense fibrosis, and once you dilate them, it's just like they recur because there's a lot of fibrosis. So sometimes you really have to remove this fibrosis, and either you remove it by stricturoplasty or even cryoablation, as recently suggested. That would be some of the options. But before we do that, certain things we have to put in our mind. Number one, there is a component of gastroparesis in all these patients. That's why he's having the reflux symptom. We could initially, before we go and see the food in the stomach, and I think he would have good amount of food in his stomach. So that should be addressed by improving gastric emptying, and options like Reglan or later on G-foam would be good in patients like that. So I have few patients that we have to do G-foam, which helps the structure of the esophagus because the food and nothing else is refluxing. Other thing is that we should biopsy the anastomosis after we dissect do the stricturoplasty. We know that this is a benign stricture, but every once in a while you may have recurrence as the anastomosis. It's unlikely in this patient, but that's something we should do. Also, we should focus on examining the esophagus. We were talking here about placing esophageal stent, and we can see here, Dr. What do you think about the esophageal stent?
Yeah, so he did have a lot of reflux, and as you can see here, there's a lot of esophagitis and stasis changes. And if we place a stent across the anastomosis, that would just predispose them to even more reflux. Basically, a wide open passage between the conduit and the esophagus. So probably would worsen his esophagitis had we placed the stent.
And then if we go a little bit back, you can see here the esophagus is dilated. It almost looks like because we have a stricture for a long time, it acts almost as if you have achalasia, long-term achalasia. What happened? The esophagus gets dilated. And when it gets dilated, it creates area where fluid and food get collected. In this area, you start forming lesions. We can see here we have this raised lake-like lesion. And that's, to me, if we're going to go into the pattern here, and I'll talk for a second about the normal pattern. You see these dots here, we call them IPCL, intrapapillary capillary lesions or structures, and they are normal in the esophagus. That's normal esophagus. We just have more of them because the esophagus is inflamed. But then you come to this part here, and you can see that these structures now almost are elongated and slightly irregular. And we'll try to irrigate a little bit and see. So if we get closer, we'll find that the pattern is slightly different here. So this could be low-grade dysplasia, maybe squamous papilloma. We know that the patient is smoking, so definitely we should biopsy that. It's extensive, as you can see. It's maybe around half of the circumference in certain areas. So what we are going to do right now is a stricturoplasty and injection of steroid, and that's it. That's the best option for him. The reason is, if we put a stent, it will worsen his reflux, and also it will stimulate more fibrosis, which will make the stricture recur later on. So we are going to demonstrate the technique of
Can I ask a question?
Yes.
Does the audience, can you hear him pretty well or no? Hardly. So we can hardly hear you, but whenever you were turning your head toward the left, we heard you well. So
Okay,
can you
like
please
that?
just do the endoscopy with your head turned left the entire time, please? So I think it's the microphone. So maybe we could ask Dr. Leonore.
Can you hear this one?
That's
Yeah.
better.
Okay, I can hold it up to Dr. Hoffman.
I appreciate that. This was not supposed to be part of the roving moderator role, but I appreciate your ability, Paul. We've trained you well. Paul is currently
Very well
faculty. This
trained.
is way above his or below his pay grade, but thank you, Paul.
What about now? Is it better now or not?
No, not really. Paul's better. I don't mean Paul's better, but Muhammad, you're
Yeah.
good too.
Okay, so before we do the stricturoplasty, so honestly, you can just do it right away, but for the safety, we're gonna do some injection because there's some sort of esophagitis and he can bleed. Having submucosal injection, although it's not gonna make a big difference, it might just facilitate the stricturoplasty needle out. So I like to do it like Mercedes-Benz sign.
Can you
inject here.
explain what type of needle you're going to be using?
Yeah, so I'm going to use dual knife and start injecting. Dual knife 1.5. That's good. That's enough injection. We'll go to the upper part here.
And then
inject here too.
I missed why is it necessary to do the injection prior to the stricturoplasty?
It's not necessary at all. Actually, you don't need to do it, but because he have esophagitis, we're doing that for some sort of protection inject. It will give me a tamponade effect, prevent bleeding because of the esophagitis. We go back. So right now we'll start with incision at 12 o'clock, and we're going to use dual knife, 1.5 millimeter. So dual knife come in two lengths, 1.5 and 2 millimeter, and 1.5 is designed for colon resection, but it works very well in the esophagus. I also would like to say that you can just use the regular needle knife. The stricturoplasty has been done for years using regular needle knife with no problem. So let's get the needle out. So now we're going to start the stricturoplasty up here. And we know here that it is very short segment. So we'll start a little bit. Initially, you may not see the effect, but gradually it will start happening. And you can see just like by making 1 or 2 incisions, we already went to the stomach. We will try to go in here again. The third side.
Is
In
your-
complex picture, you may even do 6 or 7 incisions. So it's longitudinal incisions away from the muscle layer.
And this is a patient that's had a refractory stricture with dilation, I think before we saw him over a year ago. So when you're
Yeah.
doing, when you are approaching this, Muhammad, are you planning a 4-quadrant cutting or even more than that?
Yeah, so because we will see now how to open up, but I can tell right away once I did the 3 incision that I have a big area here that need to be removed. So now we're going to remove the redundant fibrotic tissue around the structure in this area. So I will do, instead of vertical incision, it will be horizontal incision now. And I will try to remove that part completely. So 1/3. I avoid going beyond 1/3 resection because you can also get more fibrosis. So now we can see it's slightly fibrotic, but it's so far working very well. I will switch now from endocut into coagulation. We can see here the fibrosis under it. So basically, we need to get rid of this excess tissue.
So Muhammad, this isn't, I mean, we set the case up for stricturoplasty, but you're doing like a stricturectomy. Am I right? Like
Yeah,
you're really
I'm
trying to
actually,
get
yeah, so
submucosal here.
this patient, yeah, so the stricturoplasty wouldn't be enough because he has a lot of redundant tissue here. And that tissue would be problematic. So either it has to be ablated or resected or even snared to open the area. But we don't want to do like a full removal of the structure. All what I'm doing here is just removing the redundant tissue that's closing the area. And you can see like once we did that, it's opening the esophagus because the problem in this structure is that area here between 5 to 7 o'clock. And even for safety, you can even put a snare now and remove this. So if we can have a snare, maybe 10 or 15 millimeter. 15 millimeter would be good.
I wonder, should we take we're getting some feedback here. I wonder, should we take the microphone that you have off and just use Paul's? I don't know. Would
Yeah.
that make a difference? And I have no idea what I'm talking about right now. Let's try that. Just take that off and then, there we go.
What type of snare will you guys be using?
So we'll use a 15 millimeter snare. But before I do the snare, I'm just ensuring that I cut safely away from the muscle layer. But we did already the cut. Once we did the cut up here and the 2 cut down there, it opened it. And once we opened it, we realized that that's the area that's causing the problem, is this tiny area here, 5 to 7 o'clock. And you can continue with the knife, or you can just use a snare to expedite it. So we're going to use a snare.
Yeah, it's opening up very nicely.
So after that, the question would be how we prevent the regrowth of the tissue in this area. So we would prevent that by injection of steroid, but I usually bring the patient back for another session of dilation 2 weeks after. I discussed that with the patient before the procedure, and I told him in order to get the best outcome, after we do stricturoplasty, we do dilation in 2 weeks, because it's still the tissue is not fibrotic enough, and you can dilate it, and then it acquires this new plasticity, and it opens more than before. So now let's open the snare carefully.
Would you dilate the same session as when you do stricturoplasty?
I avoid dilation after. Some people do, and there's some data about stricturoplasty before plus balloon dilation, and actually it works. but we'll inspect here and see after that. This close slowly. So you can see here, we have the tissue around it. Yeah, that's good. We got one part of it. We'll try to get the other part open. The new technique, if you don't want to do that, you can do cryotherapy. Like cryoablation of that area would work the same way to close. So I had few cases in which we tried cryoablation, and it worked nicely in this situation. So now we would like to use the coagulation grasper to control all the bleeding here, or we can use the tip of the snare, but we have to go to soft coagulation mode. So I'm going to use a soft coagulation mode tip of the snare, the same as you do after you do pulvectomy. And using the cap, we can identify where is the bleeding coming from. It's just a tiny blood vessel here, close to the anastomosis. Yeah. Good. And we are on soft coag. Thank you so much.
It's a nice demonstration of
tissue-
this. Oh, go ahead. I was gonna say, it's a nice demonstration of hemostasis with snare tip soft coag, and you already have the snare out, so you don't have to get other devices like coag grasper, APC, et cetera. So very nice.
Yeah, thank you. So we can see here it open, and now we can dilate, but I usually wouldn't dilate in this situation because we just did some resection, as you can see here. So it will be so. And the next step would be to inject steroid. And then I don't need to do biopsy because I have my specimen here, which is the part that caused the, so we'll retrieve it later. So now let's inject steroid. And we're going to inject Kenalog, 80 milligram. And by the way, if you don't want to do intralesional injection, you can give the patient one dose of steroid during the procedure. There is some studies from Japan that showed it works. We can see here, I hope the panel can appreciate that that particular area had very dense amount of tissue that was causing the problem. And by just taking care of that part, the area is not as bad as before.
That looks amazing. What is your approach for Kenalog injection going to be? 4-quadrant, 6-quadrant?
Yeah, we are going to use 4-quadrant injection. And when we do Kenalog, we want it to be superficial, not deep. So basically, because I did resection right now, I might not need to go like so deep into the muscle because we want to prevent fibrosis in the submucosa. So if I inject too deep in the muscle, I'm not going to get a benefit, especially after resection. So for example, the resected area here, we'll try to go very tangential, needle out, inject 1 cc. So I'm very tangential. It's not like when we do Botox injection in a muscle layer, 1 cc, that's good. And even some studies showed that spraying steroid would be enough in this situation. Inject here, 1 cc, and you can see raise, nice. All right, good. So we're gonna go 4-quadrant. We're gonna go here too, around the other incision. Inject. And then we'll do a 4th one here. Let's inject here. And you should have some resistance in this area, right? Okay. All right, that's good. And whatever steroid going above is not the needle back. It's not bad actually to see the Kenalog above the area that we dissected. That's shown in a study that's also helped. So then the next thing we need to address, if we go here and examine the stomach, what is the status of the stomach? And we can see he has large amount of food in his stomach. A lot of time, in order to prevent restricture formation, we'll have to address that. So it should be started in Reglan, or sometime we do G-poem. We can notice that the pylorus is opening, but it is slightly tight. So I had few cases that we did GPOM to prevent anastomotic stricture in the esophagus, and it does work in this situation. So we can dilate. I would ask Dr. Shah, do you dilate? And I think you would dilate now, or you would leave it alone. What do you do?
So the question is, would we dilate now? I think it looks pretty open. I personally don't think there's need to dilate. I think you did a great job. You're able to now pass with an upper scope with a cab. What does the rest of the panel think?
Yeah, I agree. You're able to traverse the stricture now and seems to be, you made a lot of progress.
Now, you mentioned your plans to bring him back in 2 weeks. Obviously, you'll probably have optimal proton pump inhibitor therapy. Would you also add Carafate during that time? Do you see any benefit in adding
Yes,
that?
that's a great point. Yeah, we were just talking about giving him Carafate 1 gram 4 times a day. And we'll also biopsy this part here. I think it will come as a squamous papilloma, and that could be managed later with some other methods.
Mohammed, in your experience after a stricturoplasty like this, do you find that just a single dilation at that follow-up session in 2 weeks oftentimes is all that's needed, or do you find that there's a series of dilations that are needed and you're having to bring these patients back frequently for a while?
Okay, so yeah, so actually, minimum is 1, and it is variable depending how much dense tissue and how much he will form this again. So you saw we removed a lot of tissue here. If I come back in a few weeks and find that he forms the same amount of tissue, dense tissue, this means that he might need stricturoplasty with frequent dilation, like maybe once every 1 to 2 weeks, up to 3 months sometimes, but hopefully that 1 to 2 session most of the time is enough. And if we even use the cryoablation as an adjunct measure with the stricturoplasty, it will prolong it. He already had a stricturoplasty 1 year ago, and it lasted him for a good while. So it seems he responded. It's just he forms the tissue. And I would tell patients like that they will need endoscopy at least once yearly after that for just maybe 1 dilation.
Would you ever consider when you bring him back doing endoscopic ultrasound to make sure there's no deeper cancer recurrence? Or you're pretty confident in the tissue you're sending today and the endoscopic appearance that there's no malignant, recurrence?
Yeah. So we can see here in the bed of the area that we can see the muscle layer. So I feel pretty confident that we get the mucosa and the submucosa. So right now we are just barely on the muscle layer here. So I would think it would be enough that the part we resected to send it for assessment.
Oh, it looks great. I agree. It's kind of more of a stricture resection than a stricturoplasty, but it looks fantastic.
Thank you. Thanks.
That's really nice. Mohammed, I'm wondering, you said they're going to come back in 2 weeks, and I apologize. I was coordinating a couple of things, but that means it has to be on my schedule. What am I supposed to do?
Yes. So in 2 weeks, we should dilate it again, because in 2 weeks, it will start forming fibrous tissue, and he will start to try to form the same thing. So while it is healing, once we dilate it, it will acquires a new plasticity of the dilation and will not close up again.
Wonderful. So I'll be sure that's on Dr. Wani's schedule then.
Yep. And are you injecting steroids at each of those dilation sessions, those follow-up sessions?
What's the question again?
Are you injecting steroids at each of those follow-up sessions?
Usually inject steroid once every 3 months, but if I'm doing tough stricture, but in this situation, once is enough. I wouldn't inject it again next time. Sometime I give 1 dose of steroid during the procedure, and that's it for the next time.
Mohammed, that's fantastic demonstration. I really appreciate your expertise and the video transmission. Thank you. We're going to transfer back to Dr. Barron, and there might be some psychology there. Todd, we're with you live. Can you hear us?
Yeah, I can hear you. So our cytology is apparently not showing anything right now. I lost my lesion, but we did a third pass, so 2 passes with the easy shot, and I did another shark core that they're looking at now. The other thing, by the way, that we can entertain, easy to do a aluminum stent into this common hepatic duct. You can see the distance from the big dilated common hepatic duct to the duodenal wall is only about 3 millimeters. So that would be another option. An 8x8 can be done. You can see the landing pad is pretty enormous right there to get in. So that'd be another thing if you wanted to, but otherwise we can do the RCP as planned. Should we do one more pass with the sharp one? Okay. All right, and then we'll decide what to do. So this is back at there's the mass right there.
Now, as far as considering the lumen opposing metal stent placement, would you wait for a definitive diagnosis or kind of confirming officially that the patient's not a surgical candidate prior to that? When would you consider kind of doing that over
Yeah, I mean,
ERCP?
the word of he looks to be not a good surgical candidate, but obviously I didn't do the head to toe, but he doesn't look to be the healthiest. But you're right, that would most likely interfere quite a bit with a resection and an anastomosis because you're going to be into the area that they would be using for their anastomosis. So you're absolutely right. I guess it would be, yeah. Just trying to get this. I don't know my own strength. You want to see the marking?
So
Yeah,
you're
good
switching
job.
needles to the Charcot, it sounds like.
Yeah, this is my second pass with the shark core needle right now. All right, so there we go. The needle is in the lesion right there. Yeah, so the key, as you know, is to try to keep the needle at all times in your view, because sometimes as you push in and out, you tend to lose the actual needle, so you have to stabilize the scope so it doesn't move out of the plane. So you rotate back and forth until you re-establish you're in the lesion.
Hey, Todd, what did they give
Yeah.
you preliminarily? Are they seeing much in the way of cellularity?
So I was gonna
This
have
could be
them
difficult.
actually view I haven't, but other than they're still looking, and I think they're looking at my third pass, which was the first pass with the shark. She said there was a lot of cellularity, but did not have diagnostic.
Yeah, and these are difficult. I mean, these are so difficult lesions. They're
Yeah.
small, and
Yep.
I have been disappointed in intraductal transduodenal intraductal sampling as well.
Don't just take
So,
that.
the cholangiocarcinomas. This could very well not be a cholangio. It could be neurofibromatosis or something else.
Yeah, right.
Not that that's ever common in our differential, but because the guy has a history of it, and
Right.
the fellow that I
right.
saw this patient with. The fellow I saw this case with had looked it up, and there's only like 1 or 2 case reports of this. So I think that maybe after 4 passes, is your plan to maybe go to ERCP then for introductal evaluation?
That's fine. Yep, we can do that.
Yeah, like was mentioned yesterday during the EUS lecture, if you have on site, it's really nice if you can get a preliminary diagnosis, but we're able to, with these core specimens, kind of look at the gross specimen. And I agree, typically around 3 or 4 passes, if there's a good amount of white core in the specimen, I typically will submit that in formalin and usually get a pretty good diagnosis.
Okay. Okay. So what we're hearing, cellular specimens, but fibrosis, no, let's see. So let me ask you a question, Raj. What is your experience if you do a needle and then you do the introductal? Does that you have obscuring of blood or anything that makes it more difficult to interpret from the cholangioscopic aspect, or not really, because we're kind of in the middle of it? Whereas when we come from the other side, we're just going to come to the stricture itself. I didn't know if you had any thoughts about how that would look after having done the biopsies.
Yeah, these cases where we do transduodenal sampling of an intraductal mass, they're kind of few and far between.
Yeah.
So I don't have a big sample size or experience with it, but I would say that to your point that you're going from the outer bile duct to the inner, but you are
Right.
definitely going into the duct too, that there can be some
Right.
bleeding, but I think in this, most of the time, I think you can distinguish traumatic
Right.
blood changes from neovascularization and tumor vessels, and that would be one thing. And then the
Yeah.
nodular intraductal mass that may be seen on cholangioscopy is often apparent. So I think
Right.
it's reasonable. It wouldn't preclude me from proceeding with ERCP and cholangioscopy. I don't know, Urban, you have significant experience with cholangioscopy and this type of cases. What is your approach here?
I think we would go for intraductal cholangioscopy. I mean, if you're looking for cholangiocarcinoma, you should be able to find it there. So I have less experience with anosmography, but I think, I mean, you do not expect cancer in that mass, do you?
Wondering if it could be a lesion like a neurofibroma,
Okay.
maybe not cholangio.
Yeah. And then the question is, it's that, he's gonna be stint dependent, obviously, you know, pretty much forever, right? Because there's not a treatment. You probably wouldn't go for radical surgery for that if it's not a malignant process. But
And that's another comment I had. You often hear about these poor surgical candidates. Then sometimes you have to operate these patients anyway, and they pass surgery nicely. So you
yeah,
have to be careful when you say that this is not a good surgical
right.
candidate.
No, I agree. But they all look their age on the operating table, right?
Yeah.
Jeff, any comments before we go to break, and Natalie?
No, I think this is heading towards introductory sampling at this point. I think that's a reasonable next step. Based on the way this looks, I wouldn't be terribly concerned that the FNA would be problematic for trying to identify the lesion and targeting biopsies with cholangioscopy. I think you'll pretty clearly see the stricture and be able to make out epithelial structure. So I think that's going to be the reasonable next step.
I would probably go to ERCP and do some brushings and introductal biopsies and defer cholangioscopy if between the three I didn't get a diagnosis, but cholangio is so difficult to diagnose. I don't think it's wrong to do the cholangioscopy this session either.
Yeah, you definitely want to do multimodality sampling on any of these. You want to have brushings and some sort of biopsies, whether it's transpapillary or site directed.
Yeah, and I think that this kind of consensus would be, it's very unusual to get this degree of consensus, Todd. So
Yeah.
I think we all are saying that we proceed with ERCP at this
Okay.
point.
Okay.
Thanks
All
so
right,
much, Todd. We'll be
thanks.
back. We're gonna go to a break
Okay.
and then be back. You don't
Okay.
get a break, Todd, but we're all
Yeah, I
getting a
know.
break. And then we'll be
All
back
right.
for the ERCP portion. Thanks so much. A really nice demonstration. Tough case.
Thanks. Yeah.
So we are going to go to an early break. It's going to be a 20-minute break. So please do visit the exhibitors. So we'll be back here at 9:30. Remember, the passports is the most exciting part other than the live cases. And yeah, we'll see you back 20 minutes. Thank you.